Good morning, everyone. I'm Laura Gottlieb, the Director of the Social Interventions Research and Evaluation Network and Associate Professor of Family and Community Medicine at UCSF in California. Welcome to today's SIREN webinar. The webinar is being broadcast over computer speakers or via a dial-in option. All participants are muted. Any comments or questions should be communicated via the chat function in the lower left-hand corner of your screen. Technical issues can also be communicated with the chat function, as ReadyTalk staff are available to assist and help troubleshoot. The slides and a recording of this webinar will be available on the SIREN website later this week. I'll start today just by introducing SIREN, the Social Interventions Research and Evaluation Network, which is a national research acceleration and translation initiative with the twin goals of catalyzing and disseminating high-quality research around identifying and addressing social and economic risk factors in the context of healthcare delivery. As part of our work around synthesizing and disseminating evidence in this space, SIREN's developed an online hub to collect existing reports, papers, videos, and other materials on social prescribing in the U.S. healthcare system. The SIREN website launched in March and provides access to resources that researchers and implementers need to implement and study this work. It includes an online evidence library, webinars and videos from the field, and a comprehensive series of screening and measurement tools. One of the most popular parts of the site is this easily searchable evidence library, which puts in one place much of the literature on social prescribing research and evaluation. The library includes over 400 entries and is growing every week. It also includes a special search function for social needs screening tools, which is very relevant to today's conversation. And finally, as part of catalyzing higher quality research, we've developed new opportunities for peer-to-peer collaboration and information sharing. We have a team that provides technical assistance to healthcare systems interested in evaluating their social prescribing initiatives. And we've begun to host a quarterly webinar series, which leads me to the moment you've all been waiting for. I have the immense privilege of introducing today's speakers, Alex Billioux and Katherine Verlander. Dr. Billioux is the Director of the Division of Population Health Incentives and Infrastructure in the Preventive and Population Healthcare Models Group and the Center for Medicare and Medicaid Innovation. He's an internal medicine physician working to improve the health of vulnerable communities through access to coordinated health systems and cross-sectoral health policy and programs. His team at CMMI is focused on designing and implementing innovative models that realign incentives and establish the infrastructure to enable and reward health systems for engaging in population health improvement by addressing multiple determinants of health to achieve better care, better health, and lower costs for Medicare, Medicaid, and the Children's Health Insurance Program. Dr. Billioux joined CMMI in January 2016 as a senior advisor to the director, and he was a 2015-16 White House Fellow. He's a part-time assistant professor of medicine at the Johns Hopkins Hospital, where he trains and mentors internal medicine residents while treating patients in East Baltimore. Katherine Verlander is an analyst in the Division of Population Health Incentives and Infrastructure at the Center for Medicare and Medicaid Innovation, working on the Accountable Health Communities model. Prior to joining CMMI, she worked at the CDC in Atlanta in the Office of the Associate Director for Policy. Katherine has previously served in the Georgia Governor's Office for Planning and Budget and as a health insurance and at the Health Insurance Trade Association of the Georgia State Capitol. Katherine has a master's in public health focusing on health policy and management from Emory Rollins School of Public Health. So we will turn this over to Alex and Katherine with many thanks for joining us today.
Well, and thank you, Laura and Caroline and the SIREN team for having Katherine and I on today. Thank you for all of you for joining. webinar today. We're really honored to be invited to speak and share a little bit about our accountable health communities model, and specifically about the CMS health-related social needs screening tool that's a really important part of the operations of this model. So today we thought we would start getting you primed with questions by just giving you a high-level overview of the accountable health communities model so that you understand the structure and really the role that the screening tool is going to play in that model. And then Katherine will talk about the development and elements of the screening tool. So for those of you not familiar with the Accountable Health Communities model, this is a model operated out of the Center for Medicare and Medicaid Innovation, which is the part of CMS that's focused on designing and testing new models of care to improve the quality of care and reduce the cost of care for Medicare and Medicaid and CHIP beneficiaries. And the Accountable Health Communities model fits in as a population health care delivery model really focused on improving the health of Medicare and Medicaid beneficiaries by addressing their health-related social needs. So why did we develop and now launch the Accountable Health Communities model? It won't surprise, I think, anybody on the call that there's clear evidence that the largest drivers of healthcare and healthcare costs really fall outside of the clinical care environment. Estimates vary between 40 to 60% of preventable health being related to social and environmental factors. And growing evidence has demonstrated that not only does this have a huge impact, do these upstream drivers of health have a huge impact on health care utilization, but that when we actually address these drivers, we can see a reduction in healthcare utilization and an improvement in health, which is very important. What I think has been missing for quite some time has been sort of two factors that will then make this evidence base really something that could be applied in practice. And one was an incentive structure for health systems, which are potentially best positioned to be focused on the health of their beneficiaries or of their patients, to actually engage in this work and engage with communities. And then the other area that was missing potentially was a platform to say, well, how do we do this? So fortunately, the work of the Innovation Center in other areas, such as developing accountable care organizations or our advanced primary care models like the Comprehensive Primary Care Plus model, have begun to change that first factor and really start to align incentives, moving our health system from a fee-for-service driven health system to one in which provider organizations take on accountability for the health and health care of a population of beneficiaries and are rewarded for keeping people healthy and reducing actually unnecessary utilization of healthcare services. And so what was left is this need to understand, okay, if now health systems are incentivized to engage their communities and their patients in this way, and we have evidence of the kinds of factors that might improve health, well, how do we do that? And that's where the Accountable Health Communities model sits. So it's structured as a 5-year model test that will identify how systematically identifying and then addressing the health-related social needs of community-dwelling Medicare and Medicaid beneficiaries will impact their total health care costs and utilization. And we use the term health-related social needs because we're being very specific about how this model is addressing these needs, but you may be more familiar with the term social determinants of health. And we know that when we start talking about addressing social determinants of health, or more broadly just social determinants, there is an inexhaustible list rather, sometimes feels exhausting, of potential factors that could be impacting somebody's health. And so knowing that you wouldn't be able to address all of these, the focus of this model was really on these 5 core needs that you see on the left side of this table that had very strong evidence, again, of impacting unnecessary healthcare utilization and health, as well as strong evidence that they can be addressed with improvements in those 2 factors. And thirdly, that community services exist in most communities to help address these needs. So the model, more specifically, just to read them out, will focus on beneficiaries' needs around housing instability, utility assistance, food insecurity, interpersonal safety or exposure to interpersonal violence, and transportation needs. These are the 5 core areas that all of the accountable health communities participating in the model, all the awardees will be screening Medicare and Medicaid beneficiaries for. But we also offer the opportunity for more community and context-specific screening for supplemental needs. This is a non-exhaustive list, but family and social supports, education, employment and income, and health behaviors, areas that we also know have a strong impact on the health of our beneficiaries. In order for communities to engage in screening for these supplemental areas, they have to demonstrate that there was an objectively identified need to address these areas, and that there's community service capacity and partners available to meet these needs. Now, having given you a bit of an overview of sort of the high-level goals, I want to talk a little bit about the structure of the model. So the actual awardees in the Accountable Health Communities model are that bridge organization, those bridge organizations at the center of this hub and spoke model. And the role of the bridge organization is really to bring together a coalition in the communities in which they serve to address both sides of these goals of both identifying and addressing health-related social needs. So at the identification end of the spectrum, you have the clinical delivery sites shown there along the top. And bridge organizations bring to the table primary care providers, emergency departments, behavioral health providers, in a bunch of different contexts, both health systems as well as standalone clinics and FQHCs. And these are the real clinical entryway into the model where beneficiaries, Medicare and Medicaid beneficiaries, will present for care and be offered screening for health-related social needs. And you'll hear more about that today. Once those needs are identified, we then have 2 different tracks in the model for how beneficiaries are then connected to care. So beneficiaries that are determined to be high risk, meaning they have 2 or more emergency department visits in the prior 12 months, will be offered navigation services in both of our tracks, both the assistance and alignment track. And those navigation services will be one-on-one provided targeted plans for addressing their health-related social needs and connecting them to the service providers. Low-risk beneficiaries that don't qualify as high risk, haven't had those 2 ED visits in the prior 12 months, will be provided a community referral summary, which will contain information about community service providers that can help meet those needs identified during screening. The model will operate for 5 years, as I noted, and will have ongoing evaluation of the impacts that this framework is having on addressing healthcare utilization, individual health status, and reports of how care is being utilized at an individual level. So we did launch the AHC model in April of 2017, and then in May we actually began with our 32 communities of awardees. They're across 24 states. We're really excited to see that really they are located in every region of the country, as you can see here, and also provide a really good mix of both rural and urban populations. It was important to us that when we speak about this area of addressing health-related social needs, that we understood how truly contextual they are, and that the model really reflects the ability to test different contexts in their ability to meet these needs as well. More specifically, here introducing our bridge organizations across those 2 tracks that I described. The assistance track has these 12 bridge organizations that, again, will be working to address health-related social needs, and amongst high-risk beneficiaries will connect them through navigation to community service providers. The alignment track, these 20 organizations will similarly be connecting beneficiaries, high-risk beneficiaries through navigation, but will also be charged with the additional step of community-level alignment, in which they bring together all of their community partners to perform a gap analysis based on the health-related social needs screening data that they have, as well as their navigation outcomes data, and then engage in quality improvement activities at the community level to address those gaps that they've identified. And that'll continue to go on throughout their participation in the model and allow us to test that role of an integrator in really improving the health of the beneficiaries that they serve. So with that background, I think we'd like to focus today on the health-related social needs screening tool. Before we do that, I'll just give you a quick update on the model timeline. As I noted, we did launch the model in May of 2017, and both our assistance and alignment track bridge organizations are in what we call the startup period. Understanding that a model like this requires community coalition, that's going to take time to really get everybody into a position where they're ready to actually begin implementing the model. So from now until early to mid next year, depending on the track, our bridge organizations are working on hiring, developing SOPs, and really getting ready with their communities to address these health-related social needs. Then in February or May, respectively, the assistance and alignment tracks will begin actual screening and navigation and referral of beneficiaries to community service needs. So with that introduction, I'd like to turn it over to Katherine Verlander now to talk a little bit more specifically about health-related social needs screening.
Thanks, Alex, and hello, everyone. As Alex mentioned, the AHC Bridge Organizations will begin universal screening at the earliest of February next year. And we laid out several requirements for screening in the model, which I think are important to understanding how and why we developed the tool, so I'm going to get into them a little bit today. So first of all, each of the 32 communities will screen in at least one of the following types of clinical delivery sites. They'll screen in a hospital, including its emergency department and its labor and delivery unit, at least one primary care provider or practice, and at least one provider of behavioral health services. Additionally, all the AHCs will use the same screening tool at all of their sites, which is what we have provided in the discussion paper and what we'll discuss today. So also, bridge organizations will be able to choose an appropriate method to administer the screening tool. So I did want to talk about this in a little bit because I know we have a lot of operational folks that registered for this webinar and that also asked questions, wondering if we have a recommendation for how to administer or where in the clinical workflow screening would best fit. In our model, bridge organizations have a lot of flexibility in how they can administer the tool. And as far as we know at this point, they're really planning to implement in a variety of ways. The screening tool could be administered by an interviewer in like a facilitated fashion, or it could also be filled out by the beneficiary themselves, either via paper or a tablet, computer, or kiosk. The screening tool, if it's delivered by a staff person, that person could be anywhere from a trained volunteer to a community health worker or a nurse, depending on how that specific bridge organization decides to set up the model. The screening can also occur at any point in the clinical workflow, as long as it allows time to distribute the community referral summary during the same visit. So at this time, we really do not have a preferred or recommended method for administering the tool, and we look forward to learning from our bridge organizations that pursue these different processes and having them share best practices as they emerge over time. So finally, the bridge organizations will make the tool available to all Medicare and Medicaid beneficiaries regardless of language, literacy, or disability status. If you are related to or in conversations with any of our bridge organizations, you may have heard that we'll be providing a Spanish language screening tool for our model participants. And this is because we expect so much participation from Spanish-speaking beneficiaries. We are looking into the feasibility of sharing that publicly as well as any other translations that we may be able to do. So I will keep rolling here to talk a little bit about the paper we published in May of this year. I think now that you know a little more about the model and the way we will be screening for health-related social needs in the model, you have the context to kind of understand the development of the tool. So we did publish the 10-question screening tool that we will use in the AHC model to screen beneficiaries for the 5 core domains, as Alex mentioned earlier, which are housing, food, utility, transportation, and safety needs. In the discussion paper, we do describe a bit of the process and the guiding principles for the development of the tool. So if you are on this webinar, you're probably tracking this pretty closely. You may have already read the paper, but I am going to hit some of the few of the key pieces as we go through here. So with the model requirements as a starting point, we, along with our contractors, began by collecting, reviewing, and categorizing existing screening tools, questions, and evidence from a variety of sources. And I think this was before the SIREN database, which would have been really helpful 2 years ago, but I'm glad it is memorialized somewhere. So through that process, we identified over 50 screening tools totaling more than 200 questions. Some of the surveys that we reviewed were surveys that screened for multiple social determinants of health, and some of them were targeted, toward particular needs. So a 20-question survey for just housing or something like that. So, and some of them were federal surveys, others were from research or clinical practice. So we obviously need a lot of help refining the list. We convened and consulted a technical expert panel that consisted of a diverse group of tool developers, public health and clinical researchers, clinicians, population health and health system executives, community-based organization leaders, and federal partners. I have a list at the end of the presentation that I'll show you and thank them because over the course of several meetings, they came together to discuss opportunities, challenges involved with screening, and they also helped us pare down the list of evidence-based questions and recommended a short list. After we narrowed down the recommendations to the 10-question set, we secured permissions from the original authors to use, copy, modify, publish, and distribute the questions for the AHC model and CMS purposes. So I want to hit on this too because we have gotten some questions about approval to use the tool. Just want to emphasize that organizations interested in using some or all of these same questions that are in the tool would need to seek their own permissions for use. So lastly, CMS and our contractor, we conducted some pre-testing of the tool before finalizing. The goals of the pre-testing were to identify comprehension challenges with questions in specific words and identify whether the tool was relevant to pre-test respondent experiences. We found that readability was high among respondents and only identified a few difficult words for respondents. So I also wanted to talk about guiding principles and just mention that there really are a lot of good social needs screening tools out there, but none of them met all of our exact needs for our model, so which is why we developed our own. We had 3 guiding principles during the development that we lay out in the paper. First, we needed a tool that was specific to our 5 core domains that had already been identified, and they needed to consistently identify a broad set of needs and early if possible. So you'll notice that several of the domains are really asking about a beneficiary's risk or also asking about risk for losing housing, worry about food insecurity, threaten to have their utilities shut off, or risk for violence. This is a recommendation from the TEP, and we thought where possible we want sites to be able to make referrals that can help beneficiaries avoid major issues by keeping them safe, fed in their housing with their heat on before something goes worse. So we also wanted the tool to be short to allow for inclusion of routine screening and busy clinical workflows. We know you're busy. And also readily understandable to the broadest set of folks, the broadest audience. You saw our bridge organizations and where they're located, and Alex went into that a little bit, and also we're Medicare and Medicaid, so just a really diverse group that will be screened using this tool. Finally, we wanted the tool to be evidence-based and practically informed. So where there were questions or short question sets that have been validated for a particular domain, we gave those priority. Where there weren't validated questions or sets, we focused on questions that have been broadly used in practice and were recommended by the TEP. So I will start going through the questions briefly. Based on the pretest findings, we did make slight revisions to the questions that have been shared in the paper, and I will go through those quickly now. The first question, so the first domain I'll go through is housing, and the first question is from the Prepare assessment tool developed by the National Association of Community Health Centers, and is intended to identify beneficiaries who are homeless or at risk of losing their housing for any reason. The second question is adapted from Narezaman and colleagues and is intended to identify beneficiaries living in substandard housing. So I just wanted to point out, for the housing domain, the actual biggest change we made during the finalization process is we changed housing to living situation throughout. And this is because we found that about half of the pretest respondents associated the word housing with public housing or Section 8 vouchers. So we also, based on pretest respondent responses, we also changed bug infestation to pests, bugs, ants, or mice. Moving on to the food domain, we adapted these questions from the Hunger Vital Sign, which is a published 2-question food security screening tool, which has been shown to be sensitive, specific, and valid when asked of low-income families with young children. And just one change from what was shared in the paper is that we changed the introductory text to include you and your household rather than just you. And we wanted to be clear, especially for proxies that were answering for children or disabled adults, that we were interested in the household food security. So during the pre-testing, we had some parents that were answering on behalf of children, telling us things like, well, of course my child doesn't worry about food because I don't tell them my worries. I don't put that on them. So we made that change just for clarity. And then on transportation and utilities, the transportation question was also adapted from the Prepare assessment tool. It used to have 3 answer options, one for yes, medical-related meetings and appointments, yes, other, and no. And we, because in our model, the specific transportation need will be identified and addressed through either the referral or navigation process, we streamlined the answer to a simple yes, no. And the utilities question is adapted from the validated Children's Sentinel Nutrition Assessment Program survey, and no changes were made during finalization. So on the safety domain, which is the last domain I'll go over, we included 4 questions on interpersonal safety intended to identify exposure to intimate partner violence, elder abuse, and child abuse. We adapted these questions from the Hurt, Insult, Threaten, and Scream instrument, which has been validated in multiple settings around the world for use as either self-report or clinician-administered tool to identify intimate partner violence among women and men. So in order to broaden the scope of these questions beyond intimate partner violence, the TEP recommended editing the question stems to say anyone including family instead of your partner. In pre-testing, we found that some respondents narrowed in and only thought about family with that language, so we tested anyone including family and friends in the second round and found this helpful. That this helped respondents think more about just their family. And then the next is just the end. So we changed the question stem throughout the 4 safety questions. So I did also want to mention again that bridge organizations do have the option of adding CMS-approved supplemental domains and questions to their screening tool. With input from our TEP, we did land on the following supplemental domains: financial strain, employment, education, family and community support, physical activity, substance use, mental health, and disabilities. And we are currently exploring making these question selections public as well, just as an FYI. So based on your registrations, I know that many of you are most interested in implementation and evaluation of the tool. So I think we wanted to share as much as we could, as much as we're able to at this point, on those pieces based on your registration questions. So as I mentioned previously, there will be a lot of flexibility in the way that AHC Bridge organizations decide to implement the tool at their participating clinical delivery sites. Some will be integrating these questions into existing electronic health record systems. Others will be using another type of software, such as maybe a health information exchange or a vendor that specializes in social needs, referrals, and navigations and integrates with electronic health records. Still others will be using the CMS-provided web-based system for carrying out the screening, referral, and navigation. I think that some will have trained screeners to administer the tool. Others will rely more heavily on having the beneficiary fill the survey out on their own. Some sites will complete the screening during check-in or maybe vitals. Others may do it at discharge planning. So we're encouraging our bridge organizations to do this planning now with their specific clinical delivery sites to understand what will work best for each specific context. We also encourage bridge organizations to use framing language for introducing the tool to beneficiaries, but we're leaving it up to them to anticipate the needs of their populations and any organizational, local, or state guidelines or requirements. So every CMMI model has what we call a learning system where model participants can share resources and best practices with us and one another. And over the 4 implementation years of this model, we will monitor and use the use of the tool and solicit feedback from our bridge organizations on what's working and what isn't working with the tool and tool delivery. We may make changes to the tool if any significant issues are identified. We do want to be flexible and we want to monitor for issues, but we will also need to balance those considerations with any potential impact on the evaluation of the model intervention. And I know you all want to know more about the evaluation of the model. Maybe Alex can add on, but at this time, I think that we have not released our request for proposals for the evaluation contract, so we are limited in what we can discuss. We can say we'll be looking at inpatient and outpatient healthcare utilization and impacts on beneficiary health and quality of care. We'll also be collecting beneficiary-level screening results as well as information on the referral and navigation services that are provided, if applicable. Maybe, I don't know if you wanted to add anything there, Alex, before we get to questions. Okay. So I think with that, I did, like I said, want to share the list of our technical expert panelists and thank them for their commitment to the model and the development of the screening tool. I'd also like to thank our CMS team and our contractors that have helped to identify the research and tools, convene the TEP, and do all the work of pre-testing the screening tool and rolling that out. Also, a big thank you, of course, to our bridge organizations who have already been establishing great community relationships, working hard with their clinical delivery sites to plan for working this in, and are really I think we consider them pioneers in this area, and we're excited to continue working with them. And also to SIREN for inviting us to share on this webinar and for the work that they do. And so with that, I think I'll pass it back to Alex to see if you had any kind of closing thoughts or response before we move on to questions.
Well, I think instead I'll share largely an observation. I see that there are lots of questions that have been rolling in as we've been talking, and I think at this point probably the best thing would be to start answering those. So again, thank you for your time and attention, and looking forward to sharing as much as we can.
Great. Alex and Katherine, thank you so much for this great presentation. It's super helpful at understanding where the questions come from and how they are likely to be incorporated into workflows. We have a lot of questions that came in during the registration process, and then a number that are rolling in now. I think one of the questions that has been repeated a couple of times is, Katherine, you mentioned that people who are not participating in the AHC demonstration sites would need to contact the people who developed the questions for permissions. And a couple of people have asked if the list of folks that they would need to contact for permissions could be made readily available by CMMI. Is that something that might be posted somewhere?
Yeah, so I did see that question come up quite a bit, and it's one that we do get frequently. So the top line answer is that actually that information, all the references that we used to identify the question authors and owners is in that National Academies of Medicine paper that we were discussing through this presentation. I will say that we've been really encouraged by the level of interest that we've seen in the screening tool, and certainly the level of interest in adapting and using the screening tool outside of our bridge organizations. So we are currently working on developing a process. We're cognizant of the fact that These question developers are very kind in giving us permission, and we're now about to send them a deluge of people on an ad hoc basis. So we're trying to develop a process that would allow that to be a little bit more streamlined, both for you, the people interested in using those questions, and for the folks who are going to be receiving those requests, so that they're not just getting lots of emails at random. So stay tuned for that. We are working on that, and hopefully we'll have a more dedicated process for this work for you soon.
Very helpful. Thank you. Another question that came up both pre-webinar and during the webinar relates to how you're defining universal testing and then just the frequency of screening. So is the screening being recommended at every visit, once per year? What's the general recommendation both for the CMMI demonstration sites and then if you have any for outside the demonstration sites?
Sure, this is Katherine. I can answer that at least for our model. I don't know if we're there yet to make recommendations for the entire field. I think that's one of the things we hope to learn. But in the AHC model, the standard is universal screening of every Medicare and Medicaid beneficiary that has a visit at a participating clinical delivery site. So I think we want to make sure that there is no intentional or unintentional bias in potentially screening, folks that may look like they need it or may not look like, or not screening folks that they, don't look like they need it from a clinician or from anyone's perspective. And so we want to make sure that the standard is universal screening. So if they're an eligible beneficiary entering a clinical delivery site that's participating in our model, the expectation is that they're screened at that visit.
Great. Thank you. Another question that came in, Alex and Katherine, was related to whether the pre-testing included anything about the time that it may take to administer the tool. And then a related question, the number of patients that were incorporated or participants that were incorporated in the pre-testing that you talked about.
Sure, I can. I don't have the exact number in front of me for the pre-testing, but I think it was around 100 total involved. That might be a little bit high, but in that range. And then for the time, we timed two different ways. We timed a beneficiary filling out the survey, the screening tool on their own, so just reading through a paper form and answering the questions on their own. And that took around a little less than 5 minutes. And we also timed an interviewer-facilitated screening where an interviewer read the instructions, they read every question, they read every answer option, and that took a little over 9 minutes.
This is Alex. This is also a good opportunity just to highlight, I think I saw some questions during the webinar coming in as well about the delivery mode of the screening tool. And so as you can see from the way that we certainly tested or pre-tested the tool, we do envision a pretty flexible variety of ways in which the screening can take place, whether that's actually using a paper-based system in which either a screener, again, is asking questions, reading through them with a beneficiary, or that the beneficiary is handed the screening tool to operate themselves, to answer the questions themselves, all the way up to more data-driven or information technology-driven solutions like, again, self-screening, but this time on an iPad, or linking, or entering directly onto our web-based system for our accountable health communities model. So the idea is to be relatively flexible across the different types of clinical delivery sites that are dealing with different operational situations, whether it's an emergency department or a primary care office.
And just to circle up, I did find the final number after recruitment and no-shows and things like that. We completed 66 interviews during the pre-testing.
Great. Thanks for looking that up.
Yeah.
Another question came in from one of the sites, I think that is part of the AHC demonstration, asking just for clarification whether the demographics questions still need to be asked by the bridge organizations, or if it's really only the 10 questions in the AHC social and economic risk factors part of the tool.
So we're happy to circle back to any of our bridge organizations with more details. Just to be clear, what we're sharing here in this webinar are those 10 core health-related social needs screening questions that were publicly shared. As Katherine noted, we are working through the process of being able to also publicly share the supplemental screening questions. And our bridge awardees are aware that there's also sort of demographic data that we need on beneficiaries for the model operations. So our awardees will definitely be asking all of those questions. This is really to share more broadly with an audience more broad than just our awardees, the questions that we're asking.
Right. Another question that has been repeated a number of times, which I'll throw out there, with the caveat that I know that your RFP for evaluation hasn't yet been issued, so you may not be able to answer the questions that have come in around evaluation. But if there is some kind of common knowledge, broad answer to questions around what are the components or the specific outcomes that CMMI is most interested in your proposed evaluation, it looks like that is of great interest to folks.
And we appreciate that, and we totally understand that level of interest, especially given the audience on this webinar. I think what we can say is what we've shared previously, that core measures of impact for this model include emergency department utilization and inpatient and outpatient utilization amongst those beneficiaries who are in the model. We also noted, again, patient-reported outcomes would be of interest as well. This gets to that experience of care sort of metric and overall well-being. More specific measures we really can't go into at this time.
Great. Other questions relate to the translations, which I know you mentioned on the phone that you're working on the Spanish translation and will hopefully be able to share that. Any sense of when those might be available, or would you encourage places to translate the tool on their own?
So this is Katherine. We are in the process of completing that and getting clearance to share that. So I don't want to promise a specific time. Definitely will be done before January, February, because that's when we will begin really rolling it out. But we hope to have it much sooner than that, before the end of the fall.
Great. Another set of questions that came in pre-webinar and just as you were talking, Katherine, related to the decision to include 4 IPV questions in the core instrument. I think the way the questions are framed, it looks like it seems a little disproportionate, and people are wondering what the discussion was like around the IPV questions. And then whether or not CMMI is recommending that bridge organizations respond to the safety responses that are positive but don't necessarily meet the scoring threshold for a referral.
Sure. This is Alex. Actually, it's a question that we get not infrequently, and I think especially because it's the largest number of questions for any one component of the core questions. The reason that there are those 4 questions for screening for interpersonal violence is that the tool that was used, one of the most widely used and most extensively validated tools is the HITS tool, which is what those questions are based off of. And the HITS tool is a 4-question tool. So in incorporating screening in the IPV screening into our model, it was felt that it would really start to impact the fidelity to those questions if we were to do anything to reduce the number of questions. So that's why there's 4 of them. They are relatively similar in framing, though, and in the way the answer choices are listed. So we don't think that that actually contributes significantly to increased time and delivery. And you heard that some of that's been borne out in our pre-testing, that even though there's 4 questions, really what's changing are those 4 elements, the HITS, the actual STEM and the question responses are staying the same. The reason that there are those 4 responses, though, at a higher level and not having been the original designers of this model is that when we're talking about interpersonal violence, there's just a lot of different ways that that can be framed, and there are a lot of different aspects of violence that can be captured. So both physical, emotional, but also who is the person that's potentially exposing the individual to this violence. And in developing this screening tool, as you heard from Katherine near the beginning, our goal was definitely to try to cast as wide a net as possible with screening to bring as many people in to identify whether there's an opportunity to address a need that they at least may be perceiving. So the reason for bringing all these questions in is to make sure that we're not missing a domain, and then the changes to the question STEM really relate to that desire to not just have this be intimate partner violence, but to have it be really any interpersonal violence, whether that be friend, family, or other, that could be exposing our beneficiaries to this.
Super helpful.
There was a second part to your question. Oh.
If they don't meet the full.
Yeah, so under the way that the model is structured, the way the HITS questions are structured, you could theoretically answer that you are rarely exposed to actual physical violence without raising to the level of screening positive in the model. And we understand that that does have some implications for bridge organizations or others who are screening in contexts in which state or local law mandates that you report those sort of situations to authorities. And our advice, certainly within the model and more broadly, is that you should certainly comply with all of your state and local laws. And if you're unsure, really get the services of qualified legal counsel to evaluate that for you.
Thank you. Another question from the audience. Concerns from the field about the lack of an opt-out question amongst the responses, like refused to respond or chose not to answer. Any recommendations for participating sites or others doing some implementation of the screening tool around handling cases where patients are unwilling to answer certain or all questions?
Yeah, certainly. We had a robust discussion at the TEP about whether or not to include opt-out answer options. There's potential that they can encourage somebody to opt out. So we did not end up including them, but all of these questions that we've talked about here are functionally optional. So the way they're built into our data system and the way that we are having our bridge organizations deliver them and build them into any other systems are that they can be skipped. Any of these questions can be skipped without providing an answer response. So that is kind of where we have landed on how to do that. Certainly we would never force a beneficiary to answer any of these questions, and do recognize that some of these all of them are sensitive, and some of them are really quite sensitive and may be uncomfortable for some beneficiaries. So they will not be required to respond. And just for our model participants our bridge organizations on the line, the only answers that have to have questions are the answers around eligibility for the model, so whether or not they're a Medicaid beneficiary, if they live in the community, and how many emergency room visits they've had. But all of the core domain and even supplemental domain questions about needs are functionally optional.
Great. Thanks, Katherine. We have time for a few more questions. So, and thanks to the audience for these terrific questions. One of our participants asked just for clarification, you had mentioned that patients will be screened if they present at clinical delivery sites. Will the screening also be required if patients or clients are presenting at community resource sites, for instance, a health department or a social services agency?
I think that's a really great question. We, in terms of our specific model, we are only doing screening at clinical delivery sites. I will say that we have tried to be flexible in how that is defined. So if a public health department were providing a clinical service to a Medicaid or Medicare beneficiary, they could, and they were kind of in agreement with the Bridge organization that they're a clinical delivery site and they have an agreement in that way, then they could administer the screening tool to that beneficiary that's there for a clinical reason. So, we talked about like the 3 main required clinical delivery sites that have to be a part of a Bridge organization's model, but they can also include many other types of clinical delivery sites. We have seen public health departments are one example of that, often make linkages to community care and provide some clinical services, and maybe have, the WIC program managed there. So that's one we've seen. They could also do mobile visits, mobile, like, vans, I guess, like, and they could use like telehealth visits and things like that. So we've defined that broadly, but it has to be associated with a clinical visit, essentially. Not just
so another question. Oh, go ahead, Katherine. I'm sorry.
Oh, I was just saying that's just for our model, and that's what we had in mind developing the tool.
Sure. Another question comes specifically about how to administer the tool in settings where the patient is a pediatric patient. So do parents and guardians answer on behalf of children, even on behalf of adolescents, especially the safety and violence questions?
So that's a great question, and I would say a piece of that we are still researching and working to provide guidance to our Bridge organizations on. But the generally, yes, it will be parents answering on behalf of children. And one of the things we also learned in our pre-testing was that the tool, as it's written, is difficult for some proxies to answer. So we are also considering, we have provided to our Bridge organizations a proxy version of the tool where you is kind of changed to he or she throughout, so it's less of a kind of burden on the parent or the caregiver to make that transition in their head. And so when we tested a proxy tool, it did work better, so that is one consideration to think about in that environment.
Super helpful. Another question, which we did get quite a number of related questions, are around the best ways to integrate these data into electronic health records. So is it up to the implementing site to determine how to integrate these data into the EHR, or is there a CMMI plan to integrate them more broadly?
So that's a great question. We, again, received that one quite a bit. So I think one of the goals in designing this model was to ensure that the way to build a system that can systematically identify and address health-related social needs is, again, to build a system and not rely simply on the kinds of interpersonal interactions that providers and frontline healthcare providers are already having with individuals. So along those lines, the screening and referral and navigation services in this model were designed that they can happen in parallel with clinical care, but don't necessarily have to be directly integrated. That being said, we do firmly believe that to the extent that this does become integrated within care, we're going to see even more reinforcement, alignment, and improvement in the care of beneficiaries. So there's not a direct requirement that this information be encoded into electronic health records. And we'll note that some of our bridge organizations are adapting or building data systems for operation in the model, which sometimes are just adaptations of their existing EHR systems, in which case there would be that sort of seamless integration. But I think what we'll see through the model operation is a variety of different applications or different implementation styles, from direct integration of EHR to a sort of a parallel system as we currently have with the CMS system.
Super. One follow-up question from a couple of questions ago. Will the proxy tool that you mentioned with the substitutions around he, she that is targeted for pediatric patients, Katherine, will that be publicly distributed?
We have not decided that yet. We are still kind of, all these tools are happening quickly. And our pre-testing happened this summer, so we are exploring that. Yeah.
Okay. I think we are going to continue to have more resources appear on our Accountable Health Communities website, on the Innovation Center's website. And so not only for this, but for other updates, I do encourage people to go to that website. And you can sign up for the email listserv as well, but keep checking that site as we do add, as these resources do become available, we'll keep adding them to that location as well.
Terrific. There were many other questions that we weren't able to get to. We will forward everyone's questions to the CMMI team, and maybe some updates that will show up on the website will relate to some of the questions that were posed today. I definitely want to take a moment, though, just to thank Katherine and Alex for taking the time out to do this presentation with us today. And as a reminder, the SIREN website does have a collection of resources that are likely to be of interest to the participants in today's webinar today. You can also sign up for our monthly newsletter, where we'll include any updates that we hear about from CMMI. You can sign up for that newsletter on the website. You could also email us to let us know you'd like us to sign you up. The newsletter contains info on events, news items, and recent additions to our evidence library. You can connect with us via email or on our social media site as well. So again, many, many thanks to our presenters and to those of you who participated listening to the webinar today. Thank you all so much. Have a great Monday.